able to access the YouTube link that I gave you for our last meeting? Or did anybody try? I sent you a link, I believe, last night. I can send that again if you guys didn't receive the link. Today we're just going to start with chapter 2. We're not going to complete chapter 2 because it's a pretty long chapter. We're going to talk about the basis of inflammation, injury, immunity, and repair. And then there is a whole lot more that goes with that we'll talk about on Monday. Since I have trouble sharing my screen, I'll have you guys just pull this up on your screen from your module, chapter 2. So we're going to start with injury. Injury is the result of an alteration in the environment that causes tissue damage. And if tissue is damaged so badly, it can necrose, which means dying tissue. A less severe injury can end up with hyperplasia, hypertrophy, or atrophy. Hyperplasia is an increase in the actual number of cells in that area. Hypertrophy is an increase in the size of the cell, and then atrophy is a decrease in the size of the cell. So those are the differences between those three. Inflammation is how the body eliminates injurious agents that can come into our body and heal. As you guys know, hopefully itis is the suffix for inflammation. So pericornitis is the inflammation in that flap of tissue over your third molars. Periodontitis is inflammation of our periodontal tissue. So itis means inflammation. We are born with defenses in our body that help fight inflammation and infection and things like that. The innate defenses that our body provides are the physical barrier, which is our intact skin, or in our case, the oral mucosa. Mechanical defenses that we're born with are those cilia and mucus that are found in the respiratory system. Those actually help defend our body against bacteria and things like that. The saliva, as we found out in previous classes, provides an antibacterial activity in the mouth. As far as enzymes also, to help break down our foods and bacteria. Removal of foreign substances in the body, that occurs through the natural flushing of the eyes with tears, the mouth with saliva, and then urine and diarrhea for things that have invaded our body. That's how our body gets rid of those things. And then the inflammation process, which we're going to talk more about today, basically we're relying upon our white blood cells to help us with that. So those are our innate defenses that we're born with. Inflammation is a non-specific response. It depends on the extent of the injury that our body sustains. And based on that, the duration of inflammation is based on that extent. We have local responses that you'll see in the actual area of inflammation. Our body will give us systemic responses. As you guys know, acute would be something that is on quick onset and doesn't last a long time. Chronic is going to be something that lasts a long time, goes on and on for many people, or it can be a combination of acute and chronic. You're going to want to know these localized classic or cardinal clinical signs. Redness in the area of inflammation and heat are both localized signs, as well as swelling, pain, and oftentimes a loss of normal tissue function in the area of that. The systemic signs that our body can give us are fever, leukocytosis, which is an increase in the white blood cells. And as you know, those are going to be our neutrophils, monocytes, macrophages, and then all of the other white blood cells come in after that. But the neutrophils are the first responders to inflammation. We might see an elevated C-reactive protein level in blood work. And lymphadenopathy would be that hyperplasia or hypertrophy of the lymphocytes. So when we're doing our head and neck exams and we're feeling all of those lymph nodes in their neck, head region, that's what we're looking for. You'll want to kind of go through this chart in your book for the microscopic events of inflammation. I'm going to see what page that is for sure. That is on page 36. It gives you a much larger view and kind of describes that for you and walks you through that process. The actual steps are listed in box 2.1 on page 35, where it goes through all of those steps that I have listed on this slide. When inflammation first occurs, we see a constriction of the small blood vessels and then immediately a dilation of the vessels. There's an increased permeability, which allows plasma within the blood to leave the circulation through, well, it's called transjudated at that point. The blood at that point will replace the liquid portion of our blood. So as the plasma leaves the cells as transudate, that blood increases in viscosity, which helps it to slow down or stop the bleeding. Then our white blood cells will marginate and pavement the vessel wall. And it's called chemotaxis when the white blood cells travel to the site of inflammation or injury. Once they reach that area, they line the margin, and that lining of that margin is called pavementing of the vessel walls. Then the white blood cells will emigrate from the microcirculation and increase vascular permeability. The plasma is high in protein and leaves the microcirculation at this point as exudate. Exudate has a higher protein level than the transudate. It's more like a serous fluid. The white blood cells will ingest foreign substances through phagocytosis. So as white blood cells are in the bloodstream, they're monocytes until they reach the site of infection, and then they become macrophages. And as you hopefully remember from previous courses, macrophages are known for phagocytosis, and they basically get rid of all the dead, dying tissue and bacteria, and basically get rid of all the things that are keeping that area from healing. Hyperemia is an increased blood flow to those capillaries of injured tissue. So that will produce that redness that we've talked about. Exudate, again, is an increased blood plasma, but it also contains the proteins in injured tissue. So it's much higher in protein other than the serous exudate that I mentioned before, which doesn't have as much protein or white blood cells in it. Another word, you guys will want to know all of the different words for exudate. If it's a serous exudate, it's watery. If it is pus, purulent, or separation, all of those words mean the same thing. So you may see that called a purulent exudate. You may see it called pus. You may see it's called separation. What your patients are going to relate to is the word pus. I know it's a nasty word, but they understand what that is. Some of the other words, such as separation and purulent, the average layperson would not understand what you were talking about probably. So the sequence of microscopic events, you can see that I've listed it here. It starts as transudate, which is that serous fluid. It can become more like exudate with more protein, and then it will see edema, where the fluid actually goes in between the cells and causes inflammation of the tissue, or swelling of the tissue, I guess. Heat, an abscess can form, which can then lead to a fistula or a drainage path. And the exudate formation under the tissue is actually what causes pain, because it creates that pressure. There's a couple of pictures in your book on that same page 36 and 37, where it shows an intraoral abscess that has been incised and is draining. They place that tube in to allow that exudate to drain from the tissue. In this particular case, that would be a pretty severe case. And then the other image that is shown here is just showing the pavementing and margination of those neutrophils along the periphery of that vessel. Again, these are just vocabulary. I don't know if y'all have taken a look at the start of this chapter, but the list of vocabulary words is quite lengthy. I would just kind of go through those, which I do every single time I teach this class. I go through all these words and make sure that they're clear in my mind of what they mean, so that as you're going through this, you kind of understand what they're talking about. So I would encourage you to do that and make sure that you understand those words and what they mean. Okay, so white blood cells are huge in the inflammatory response. Like I said, the neutrophils are going to be our first responders. Neutrophils are also called polymorphonuclear leukocytes, so you might see them noted as PMNs as well. Monocytes are what we call the second responder when it is circulating in the blood. Once that monocyte reaches the tissue, it becomes a macrophage. Lymphocytes and plasma cells are then called upon after that, and they are seen more often in chronic inflammation and in our immune response. And then the eosinophils and mast cells would be seen in both. So if we're looking at white blood cells' response to a chronic inflammation, you're going to see that as inflammation continues, the number of neutrophils will decrease, because like I said, they're their first responders. So for people that have chronic ongoing inflammation, the neutrophils are going to kind of level out after a while. In acute inflammation, we're going to see more neutrophils and then those macrophages, because that's quick onset and quick to heal. So what do you want to know about neutrophils or PMNs? You want to know that they are the first white blood cell that is recruited to an area of injury. They make up 60 to 70% of our white blood cell population. And as with most cells, they are derived from stem cells in our bone marrow. Like this chart, 38, and it shows other. And when we talk about immunity, if you look at the bottom of this chart, it talks about lymph tissue and us to the B lymphocytes, T lymphocytes, which is our immune response, basically. You migrate from the vessels to that injured tissue. Hello?
Professor Bowles? Can you hear me?
Uh-huh.
Your audio is cutting out really, really bad. Like, I think we just missed that whole thing you said. The last thing I heard was about PMNs are the first to go to the area of injury.
Let me go back here. Have you heard me up till then?
Yeah, it cut out a little here and there, but I was able to kind of put it together. But that last thing I just completely missed.
Okay, I'm going to step out on my porch and see if it's better out there because I'm down in the boondocks. What? Oh, okay, so it's windy outside. The wind chimes are going and there's somebody mowing. So I don't think that's probably a good idea. How am I now?
I think it seems okay now. Like I heard you just now.
Okay, let's try. I've kind of moved my computer a little bit, so we'll see if maybe my microphone is up here. Maybe it was getting kind of blocked. So we'll start the being recruited.
It's all your audio is all gone again.
Blood cell and derived from stem cells. It's in and out again. I'm going to change. I'm not coming over there. Okay, guys. Is this any better? Nobody can hear me? Can you guys hear me now? Are you guys saying yes to me continuing or to me doing a voice over the PowerPoint?
Did you guys already go over the quiz?
No, we're lecturing right now.
Oh, okay.
You guys can hear me now? Okay, I will continue. If I'm going to keep my eye over here on the chat. If you lose me, then I'll pick back up. I'll finish off with voicing over my PowerPoint so that you guys can hear it entirely. I'm going to start from the neutrophils again. You guys should never forget this since I've said it, although maybe you haven't heard it at all. Neutrophils are the first white blood cell recruited to the area of injury. They make up 60 to 70% of the white blood cell population. And as with all blood cells, they are derived from stem cells in bone marrow. And this is the chart that I was telling you guys about that you can find on page 38. And I just think that that's a really good visual to kind of make that stick in your head where all those blood cells come from. And next chapter, we're going to talk about immunity and the immune response, which will be the lymphocytes, which you can see at the bottom of that chart. So we'll be referring to that again. They are in tissue, and they are our second responders to emigrate to an area of inflammation. The macrophages are important in phagocytosis to get rid of basically the garbage, the bad necrotic tissue, the bad cells. They basically get rid of all of that so healing can occur. Macrophages make up only 3 to 8% of our white blood cell population, and again are derived from those stem cells. Just a picture of a macrophage and what they look like in their big nucleus. Okay. In our body, we've got some biochemical mediators that are also involved in this whole process. These mediators will instigate the events of that inflammatory response, and they can be derived from blood, our endothelial cells, which are the cells that line endothelial tissue. They can also be derived from our white blood cells and platelets. Pathogenic organisms can also have a role in this as they injure the tissue, causing these mediators to kind of head up these events. So there are 3 interrelated systems in our body. The kinin system, and those are on page 40. It mediates inflammation by causing the increased dilation and permeability of our vessels at the site of injury. The clotting mechanism is kind of self-explanatory. It is very important for that clot to form. It forms almost like a mesh so that blood collects in it and forms that clot that stops the bleeding. And then the complement system is composed of many proteins that are kind of activated in a cascading fashion. One protein will activate the next protein, which activates the next protein to make things happen in that whole inflammation process. So again, the kinin system is active in the early stage of inflammation. It will activate substances in that plasma, which is the liquid portion of our blood, as well as in the injured tissue. So it's going to cause the dilation of blood vessels at the site of injury, and then permeability of the vessels so that plasma can come out as transudate of the vessels, and it will induce pain. Clotting mechanism clots the blood and mediates inflammation. And then that complement system, like I said, is that production of those cascading effects of plasma proteins. The antibody or antigen complex initiates the sequence of steps. Plasma proteins will function in inflammation as well as immunity. Some components of this can cause white blood cells to release histamine. Histamine increases the vascular permeability and vasodilation. Histamine is something that is used also in our allergic response. Some other components can cause cell death or necrosis from or form chemotactic factors for those white blood cells, or enhance or enable that phagocytosis of the macrophages. Some other biochemical mediators that are released in the body are prostaglandins. And again, they're going to be important in vascular dilation and permeability. They have a role in pain and red area, and also changes in that connective tissue where inflammation is occurring. We've also got lysosomal enzymes that act as chemotactic factors and can cause damage to the connective tissue and to the clot. So those are other biochemical mediators. The pathogenic organisms that are in our body can release endotoxins. These are produced by cell walls of gram-negative bacteria. They can serve as a chemotactic factor and activate complement functions such as an antigen or damage to the bone and tissue. And then those lysosomal enzymes can have a similar chemical composition and action as those we see with the white blood cells. Basically, with these biochemical mediators, those first three, the kinin, the complement, and clotting mechanisms, are the ones that I'm going to want you to really know. The ones beyond that, just know that they exist. I'm not going to ask a lot about those. So just know those basic three for my tests. The systemic clinical signs of inflammation are very important. You want to know these as well. Fever, just when you think systemic, just think something that isn't local, like redness and inflammation is localized to that area. You can actually see it where the injury has occurred. Or systemic is going to be something that is all over your body. So fever, that's a systemic response. An increase in white blood cells, that's a systemic response. The elevation of your C-reactive protein, systemic, and then lymphadenopathy. We've got lymph nodes all over our body, so that is systemic. So know that those are the systemic clinical signs of inflammation. So the fever is controlled by the hypothalamus. Anything that can induce fever would be called pyrogen. So fever-producing substances can be produced by white blood cells as well as pathogens. And actually, a fever is your body's attempt at healing inflammation or an infection. So in some cases, they don't want a fever to go above a certain degree, but in some cases, they almost like to see a person withstand or have that fever for a little bit because it helps to fight the bacteria. So pyrogens will act on that hypothalamus because the hypothalamus is it's kind of our thermostat of our body. So the hypothalamus will increase our body temperature to combat those invaders or bacteria. Some systemic manifestations, leukocytosis. Leukocytosis is that increase in blood cells. The normal number of white blood cells we should have in our body are 4 to 10,000. So if we have an inflammation or an attack, the response can increase those numbers anywhere from 10 to 30,000. So anything above 10,000 is considered high. Anything below 4,000 is considered low. And many times when people are undergoing like chemotherapy or radiation, those white blood cells drop, which is why they are so susceptible to infection because they don't have enough white blood cells on board to fight that. The body's attempting at this point to provide more cells for phagocytosis. When we see this number go up, it's fighting something. So they know if they take your blood and they do a CBC, a complete blood count, they know if those numbers are high that something's going on. Your body is trying to fight something. I think this is kind of interesting because the type of white blood cell that is increasing can give them an idea of what kind of infection they're dealing with. So if you're fighting a viral infection, many times we're going to see those lymphocytes increase more. If you're fighting a bacterial infection, it's usually the neutrophils that we see in higher numbers. And then an allergic response, we're going to see those eosinophils climb. So I think that's kind of interesting. That's a way for them to kind of decide what kind of infection they're dealing with. The lymphadenopathy are enlarged, palpable, superficial lymph nodes. Now, as we know in clinic, we see that all the time. We see lots of enlarged submandibular lymph nodes. Maybe they're bilateral, maybe they're unilateral. They're usually movable. Movable is better than non-mobile. Non-tender. Non-tender doesn't always mean that it's okay. Cancer has often been called the silent killer because people don't have pain until it's pretty severe. Sometimes, not always. But so we always want to note those. We want to note if they're mobile. We want to note if they're tender or non-tender, if they're bilateral or unilateral. And then I always ask questions of my patients. Do you have chronic sinusitis? Do you have allergies? Have you been fighting anything recently? Sometimes even if people have like a toothache on one side, you'll feel a lymph node inflamed on that side because it's fighting that infection and it's draining that out through those lymph nodes. So we can see that even in oral inflammation. Okay, so lymphadenopathy, like I said, occurs because of changes to the lymphocytes. That enlargement can either be due to hyperplasia, which is an increase in the number of the cells, or hypertrophy, which is an enlargement of the cells. The way I remember those differences is I think of like a muscle. Hypertrophy of a muscle means like the cells are getting bigger, like your muscles get bigger when you work them out. You're not actually creating more muscle cells, you're enlarging what you have. Hypertrophy is the opposite of atrophy. So when I broke my foot and I had to have a cast on up to my knee, when they took that off, my calf and my leg on that right side looked super scrawny, like a little toothpick next to my other leg. And that's atrophy because those cells actually shrunk in size due to lack of use. So that's kind of how atrophy versus hypertrophy, and then hyperplasia is an increase in the number of cells. Some images for you to kind of look at. These are also in your book for lymphadenopathy on page 42, and it points out all of those nodes that you guys have learned in head and neck anatomy and where they're located, and the ones palpate and their names. Okay, the C-reactive protein. C-reactive protein is produced in our liver, and it will interact with that complement system in that cascading effect of proteins. These levels can be used to help assess rheumatoid arthritis, systemic lupus. My dad has polymyalgia. This is something that they checked on him quite often to see kind of where his body was. Are we in a state of inflammation, or are we kind of in remission right now? It's also used to monitor that tissue healing as an early infection detection system. This would have to be done through labs. So they would have to have blood work done, and so you'd be using your laboratory diagnosis process for this. And this can be chronically increased in people that have an increased risk or it can cause them to have an increased risk for heart disease, cardiovascular disease, and they even think it could possibly be have a role in periodontal disease. So that's kind of an interesting fact. So chronic inflammation, again, is caused by persistent injuries. The repair cannot be completed until the source of that injury is removed. So the cells that are involved in that, in the chronic inflammation, are going to be those macrophages, the lymphocytes, plasma cells, neutrophils, monocytes, as well as fibroblasts. Many times with chronic inflammation, we'll see formation of granulomas. And I know that I've worked with some of you in clinic, and we've talked about granular tissue that comes from the pocket as you're scaling. You can pull out lots of tissue. I've had some students even think they've done tissue trauma, and actually you're just getting rid of that unhealthy lining of the pocket, which is due to chronic inflammation from their periodontal disease or their gingivitis. And we're getting that out and kind of giving it a fresh new start when we remove that tissue. So what a granuloma or granulomatous tissue or inflammation actually is a group of macrophages that kind of group together to form, I don't know, they form these giant cells, and it just forms in an area of chronic inflammation. So I guess that's the best that I can do in explaining that. We see granulomatous areas with tuberculosis. We see these big lesions on the palate, on the tongue in these patients. So we will talk more about that as we get into specific diseases and manifestations from that. So what can we do for anti-inflammatory? I don't know where you guys are in pharmacology, but some of what we're going to learn in my class will hopefully overlap and kind of solidify your learning in pharmacology as well. Non-steroidal anti-inflammatory drugs, or the NSAIDs, are aspirin, ibuprofen, things like that are used for inflammation. The steroidal and anti-inflammatory drugs are going to be your steroids like prednisone. Those are often used for inflammatory conditions. I know that's what they gave me when I had poison ivy, and I could not get rid of it. I looked horrible. I looked burned, and I am super allergic. So I had to go in and have shots of prednisone in order to get mine under control. Benadryl is an antihistamine that is often used for allergic response. And then there's a bunch of cancer treatment drugs, methotrexate, sulfasalazine, leflunomide, cyclophosphamide, and mycophenolate. The only thing I don't want you to, necessarily memorize all those drugs. I'm sure you'll probably have to know those for pharmacology. But the cancer drugs are often used for chronic inflammatory situations such as lupus. And like I said earlier, what that causes is it can help them with their inflammation, but it decreases their ability to fight infection. So their white blood cell sometimes are affected, and their ability to fight infection is decreased. So these people are immunocompromised. So some reactive tissue responses that we can see are hyperplasia. You guys will talk about this in pharmacology too. We see gingival hyperplasia in some patients due to drugs such as Dilantin, anti-seizure medications, things like that, calcium channel blockers. Those can all cause gingival hyperplasia. Why is that important to us? Because keeping a patient's mouth clean and plaque-free when they've got huge overgrowths of gingiva is very, very challenging, not only for us, but also for them. So that's hyperplasia, which again is an increase in the number of actual cells. It can also be due to chronic irritation or abrasion. It can return to normal if the insult that is causing the hyperplasia stops, or it can even continue after the irritant is removed. Again, we talked about hypertrophy and atrophy, so that's just a repeat. So regeneration and repair. Regeneration is the process by which injured tissue is replaced with tissue identical to that was present before the injury. So some injuries can actually regenerate back to where they were prior. Repair is the restoration of damaged or diseased tissues. Sometimes we are able to repair back to and regenerate to where that area of injury was prior to the injury, and sometimes we're not. There are microscopic events that occur, and this is going to be on page 44. A small injury many times just involving the epithelium and connective tissue will regenerate and repair and will leave very little scarring. As you can see, what happens as a larger injury occurs, a larger clot occurs, the surface layer can sometimes leave a larger scar if that injury is large, which makes sense, and you guys know that. You've gotten little scratches, it's healed, nobody knows. You've had something really big and you've got a scar from that. So that's basically what we're saying. So the microscopic events that occur with an injury. On the day of the injury, the blood flows into that tissue and it produces that clot. That clot contains fibrin and those clumped red blood cells and platelets. So that's what protects that, so that all of that healing and regeneration of tissue underneath can occur while that scab is basically what we're talking about on top. That's why you shouldn't pick those off, because if those are allowed to stay there, they're kind of protecting what's happening underneath. And that's why they say, you know, if you pick the scab off, it's going to scar worse. Well, it could, because you're not allowing everything underneath to heal the way that it should. So the day after the injury, those neutrophils will emigrate from the microcirculation to that tissue in an acute inflammatory response. So this is, you know, neutrophils are the first responders. So this is going to be in the very beginning of that occurrence. Then those monocytes are going to travel out there, become macrophages, and phagocytosis is going to occur. And that occurs here on a couple of days after the injury. Those monocytes, like I said, will change to macrophages, continue to phagocytose, and stimulate the growth of new vessels in a process called angiogenesis. That's one of the vocab words for this chapter. And if you think angio, I think heart, I think blood vessels, those kinds of things. So new blood vessel growth is angiogenesis. At this point, you know, the neutrophils are going to start decreasing in number because they've done their job. They were the first responders. They flew to the site of injury. Now it's the monocytes and macrophages that are going to take over and try to gobble up the trash and get it out of there so healing can occur. Those fibroblasts will increase in number and produce new collagen. And I think of collagen as, if you think of the fibers that support our teeth, I always think of fibroblasts and fibrinogen and all of that stuff associated with collagen and fibers. They just kind of go together. So anytime collagen is involved, we know it's fibroblasts making those fibers. Then granulation tissue, which we were talking about, forms. And epithelialization is the process by which new surface tissue, epithelium, is created. Knowing some of your med terminology and just using knowledge that you guys already have with some of these words, you can almost kind of define them yourself just by the prefixes and that you see in these words. The blood clot is now going to act as a scaffold for new connective tissue. The lymphocytes and plasma cells will migrate to that area as chronic inflammation and that immune response is going to begin. So here we are 7 days now after the injury. Immune responses are completed if the source of injury is removed. Fibrin is digested by the tissue enzymes, so that scab or top layer is going to slough off on its own, which means that that initial repair is completed. And as you know, when that scab does come off on its own, that tissue is pretty thin, pretty red, sometimes even tender. It's healed, but it's not fully, it's not at its full strength yet. Those are immature collagen fibers. They're pretty fragile. It would be easily injured again if you bumped up against it. So that's where we are in about a week. Then after 2 weeks, that initial granulation tissue and its fibers have remodeled. They've matured. That fibrous connective tissue is now called scar tissue. And that layer now is whiter and paler due to the increase in collagen. and decrease in vascularity. And at that point, it's considered fully healed. The factors that can affect the amount of scar tissue, some people form lots of scar tissue and scar badly, and some people don't. Heredity can have an effect on this. So if you look at your parents or family members and they've had a history of scarring, you may too. Some other factors are the strength and flexibility that is needed in that tissue. Depends on where the injury is and how much abuse that area is going to take. And then the type of repair. We've got 3 different types of repair. We have healing by primary intention, secondary intention, and tertiary. Those are found on page 45. Healing by primary intention is where there's little loss of tissue. So the margins are pretty clean and close together, and that very little granulation tissue forms. I always think of like a surgical incision, a nice, neat incision. The edges are going to form back together. It's not a large area. It's going to heal nicely, and there's going to be very little, if any, scar tissue from that. Then we have healing by secondary intention, where the edges of the injury cannot be joined together. So let's say you're running down the road and you fall and you have this huge gash. Okay, those edges aren't clean and smooth. So that's going to be harder to join together, and there's probably going to be a larger clot forming, and it's going to result in more granulation tissue and probably more scar tissue. Some people will even form excess scar tissue, and that excess scar tissue is called a keloid. This is more often seen in people that have more highly pigmented tissues, so African American, maybe Native American. People that have darker skin tend to have a history of this keloid formation for whatever reason. You can see here's a picture of a large keloid scar behind this man's ear. They go in and remove that surgically, but oftentimes I had a student that actually had one on her ear, and she was African American, and she had it removed. Her parents had fought it too, and she had it removed, and it came back. In fact, not very long ago, she sent me a little deal saying, here it is again. My friend is back. So many times this keloid tissue will come back even when it's removed. Healing by tertiary intention is delaying a surgical tissue repair until infection is resolved. So an injured area can become infected, especially in puncture wounds, and in some situations that infected area is left open to heal. I had a friend that her C-section scar got really badly infected around the staples that they had used. So they had to open that back up, clean out all the infection, and they had to actually pack that incision with gauze and clean it regularly every day and let that heal from the inside out. So that would be kind of healing by tertiary intention. The last thing we're going to talk about today is the bone tissue repair. As we know, osteoblasts are the builders of new bone. Osteoclasts will break down bone. So some things that can affect bone formation and bone repair are blood supply at the site, edema, injury, infection, removal of osteoblast producing tissues, and excessive or inadequate movement of bone. Sometimes in bone repair, they'll want the person to move that bone to build more bone. My son had an injury to his knee from jumping in a pool and hitting the bottom of his knee. It was actually, he was only about 9 and his knee was necrosing. And we had gone to say 2 different times and they kept saying, you're fine, you just need to be on it more, you need to use it more. So that's what we were doing, and he was suffering with more pain and more pain. So I took him to a specialist, and they said had he continued, he would have ended up with a knee replacement. So in his particular case, they put him on crutches and took him off of his knee for a couple of months. So not always is activity the best thing. So it's really important to, if you have something like that, to make sure that your doctor knows what the heck they're talking about. Factors that can also influence our repair of bone. This is important to us for periodontal disease. So their nutrition, as we know, we just came out of nutrition. You guys know the macronutrients and micronutrients and vitamins and minerals that are going to be important for bone repair. Their age is going to have an effect on it. The older we are, the harder it is for us to heal. Our cells we have fewer, they're lazier, they don't repair as quick as they did when we were young. And then, as we all know, tobacco use can also have a negative effect on our healing of bone. Again, the factors that impair healing, local factors would be bacterial infection, tissue destruction, hematomas, excessive movement of injured tissue and poor blood supply. Systemic is going to be your nutrition, immunosuppression for those that are on drugs or have some sort of condition that causes them to be immunosuppressed, genetic connective tissue disorders, and metabolic disorders. And I'm going to stop there today. We will start with there's a whole bunch of slides and pictures and conditions that we're going to talk about at our next meeting on Monday.